Welcome to Deep Dive Ortho, the show dedicated to bringing you the critical insights you need to stay at the forefront of our field. Today, we're taking a deep look at a foundational principle of surgical excellence, one that's, well, it's been challenged and reshaped over decades, hasn't it?
It certainly has. Practice evolves, science inquires.
Exactly. We're delving beyond that classic, almost mythical description of a successful surgeon. You know the one, Sir Lancelot Spratt in Doctor in the House back in '54. To be a successful surgeon, you must have the eyes of a hawk, the heart of a lion, and the hands of a lady.
Ah, yes, the classic quote. Evocative.
It's a powerful image, isn't it? It conjures visions of individual technical brilliance, the sort of solitary hero, a master craftsman.
The lone genius narrative.
And for many generations, that was the gold standard, really, the singular focus of surgical training. But as we navigate the complexities of 21st century medicine, that traditional view is undergoing, well, a profound and necessary evolution.
Absolutely necessary, I'd say.
While that individual technical skill, those steady hands, that precise anatomical knowledge remains undeniably vital, there's this compelling, growing body of evidence suggesting something else is equally, maybe even more, critical for patient safety and outcomes.
Something beyond just the technical.
Precisely. We're talking about non-technical skills.
The NPS factor, yes.
These often unseen, sometimes tacit but utterly crucial abilities that truly transform how surgery is performed and ultimately how our patients recover. It's a shift, isn't it? From the lone genius to the highly effective team player.
A fundamental shift in perspective.
To help us unpack this crucial paradigm shift and understand its profound implications for orthopedic practice, I'm absolutely delighted to welcome Professor Mo Imam to the Deep Dive Ortho studio.
It's a genuine pleasure to be here. This is such a relevant topic for modern orthopedics, really crucial.
Professor, that classic quote about the hawk, the lion, the lady, it really does paint a picture of individual, almost innate technical mastery. But as you've observed, our understanding of what makes a successful surgeon has broadened, hasn't it? Particularly with this emphasis on non-technical skills. How would you describe that evolution?
That's a brilliant starting point because that traditional description, while wonderfully evocative, perhaps a bit romantic even, it focuses so heavily on what we might call innate knowledge and a kind of technical gifting. It's all about the individual's physical and mental acuity.
Right.
But what it implicitly highlights, almost by its omission, is a lack of those crucial, tacit, non-technical skills we now understand are so incredibly vital. It suggests a surgeon brilliant in isolation, perhaps.
But not necessarily in a team.
Exactly. Not necessarily someone who excels within a complex team environment or under the immense pressures where nuanced communication is absolutely key.
So our understanding has shifted.
Oh, absolutely. It's broadened to encompass a far more holistic view. We now define non-technical skills, NTS, as the cognitive, social, and personal resource skills that complement technical skills and contribute to safe and efficient task performance.
Cognitive, social, personal resource skills.
Yes. And it's crucial to understand these are not soft skills in the sense of being less important or easily dismissed. Quite the opposite.
They're fundamental.
Absolutely fundamental. Hard-edged requirements, just as critical as your ability to wield a scalpel or reduce a fracture, particularly in the high-stakes, time-sensitive, complex environment of an orthopedic operating theater.
Okay, let's unpack that definition a little. Cognitive, social, and personal resource skills. That sounds quite encompassing. What specifically are we talking about here? Can you elaborate on the key components, perhaps with a touch of orthopedic relevance?
Of course, let's break it down. These skills are multifaceted and truly essential.
Okay.
For example, situation awareness. This is paramount. It's not just looking. It's perceiving, understanding, and projecting.
Projecting, meaning anticipating.
Precisely. Anticipating what's next. Being acutely aware of everything happening around you. The patient's physiological status, the exact limb positioning, equipment function, the energy in the room.
The vibe, almost.
You could say that, yes. Even anticipating the next step or potential complications. Are you really tuned in to subtle changes in vitals? Is the suction suddenly struggling? It's about building and maintaining a dynamic mental model of the entire situation.
Right. Okay, that makes sense.
Then there's team working. Surgery is never a solo act, ever.
Definitely not.
It's a carefully choreographed symphony of different professionals, anesthetist, scrub nurse, circulating nurse, radiographer, maybe an industry rep.
Lots of players.
Indeed. Effective teamwork ensures everyone works cohesively, not just in parallel, towards that common goal. Imagine a complex hip replacement. If the scrub nurse isn't anticipating the surgeon's next instrument, or the anesthetist isn't communicating a blood pressure drop effectively,
Hmm.
the whole flow is disrupted. Patient safety is compromised.
And leadership, that's another one, isn't it?
Leadership is critical. And importantly, it's not solely the domain of the lead surgeon.
Ah, interesting. Distributed leadership.
Exactly. Different team members might need to step up at various points. Who takes charge during a sudden bleed? Who guides decisions, clarifies roles, fosters an environment where everyone feels empowered to speak up?
Which ties into communication, presumably.
Directly. Communication is arguably the bedrock of all NTS. Clear, concise, closed loop, timely information exchange. It's paramount.
Closed loop, meaning confirmation.
Yes, confirming the message was received and understood correctly. Misunderstandings, lack of information, or someone being unable to voice a concern, however minor it seems, can have catastrophic consequences. Think about a timeout protocol.
The WHO checklist.
Yes, if it's rushed, perfunctory, or if someone feels uncomfortable raising a concern about, say, the side of the body, that's a failure of communication and leadership right there.
And what about managing stress? Coping with fatigue? That must be huge in surgery.
Absolutely. Managing stress and coping with fatigue, let's be honest, these are inescapable realities.
Long hours, tough cases.
Exactly. High-pressure cases, demanding schedules. How one handles these directly impacts performance, decision-making. A surgeon aware enough to recognize their own fatigue, or a team leader who can de-escalate stress in the room. That enhances safety.
And finally, decision-making itself.
Decision-making, often under significant pressure, with incomplete information, sometimes competing priorities. All these skills, situation awareness, teamwork, leadership, communication, stress management, decision-making, they're deeply interdependent. They form a robust framework far beyond just manual dexterity.
That's a truly comprehensive breakdown, and the examples really bring it to life. I've heard these terms, NTS, often used alongside others like human factors and crisis resource management. Are they all essentially referring to the same thing? Or are there nuances? It can feel like a bit of a terminological thicket sometimes.
That's a very astute observation. It is important to clarify, as the terms are often used interchangeably, but understanding the subtle distinctions helps appreciate the full scope.
Okay.
Human factors is perhaps the broadest umbrella. Ken Catchpole defined it as enhancing clinical performance through an understanding of the effects of teamwork, tasks, equipment, workspace, culture, organization on human behavior and abilities, and application of that knowledge.
So it's about the whole system.
Exactly.
Yeah.
How all these external elements, the OR layout, hospital culture, tool design, interact with human behavior to either help or hinder performance, making work more human-friendly, error-resistant.
Right. And NTS fits in how?
Non-technical skills, then, are the individual, cognitive, social, personal abilities, the situation awareness, the communication we discussed, operating within that broader human factors framework. They're your personal toolkit, if you like.
Okay, toolkit. And crisis resource management, CRM.
CRM is the training and application of these principles, often learned through simulation, specifically to manage critical events effectively. Think of it as the flight simulator for your brain and team.
The emergency drill?
Precisely. Training you to deploy those NTS under extreme pressure, often for the first time outside a real crisis. So, human factors designs the cockpit, NTS are the pilot's inherent skills, and CRM is the emergency landing drill.
That's a great analogy.
They're intimately related, describing the same crucial concepts, just different lenses. The key takeaway, they all underline the critical role of these skills. But what's striking, as we touched on, is this gap.
The gap between knowing they're important and actually teaching them.
Exactly. There's consensus among faculty that these skills are vital, need dedicated teaching. Yet they're often not explicitly, systematically addressed in traditional surgical training. That creates a significant, potentially dangerous gap.
Professor, that's where the plot truly thickens. This disconnect between acknowledged importance and formal training. It's striking that NTS are seen as central to patient safety, not just technical skill. Can you elaborate on the evidence linking deficiencies here to adverse outcomes? Because for so long, the focus was almost purely technical error.
Indeed. The evidence isn't just compelling, it's unequivocal. NTS deficiencies are a silent yet incredibly powerful culprit in medical error. This isn't just theory, it's reality in our hospitals.
So where did this realization really crystallize?
One of the seminal reports was To Err is Human from the Institute of Medicine in 1999. Shocking focus, frankly. It revealed staggering statistics. 44,000 to 98,000 deaths annually in U.S. hospitals due to preventable medical errors.
Preventable, that's the key word.
Absolutely. These weren't just unavoidable complications, they were preventable failures within our systems. The sheer magnitude sent shockwaves, forcing a fundamental rethink. The insight wasn't about bad doctors, but flawed systems and human factors, creating conditions for error.
A shift from blame to system.
A huge paradigm shift, moving from individual blame to collective responsibility for safety. And when you delve into root cause analysis of adverse surgical events,
Trying to find out why things went wrong.
exactly, what consistently emerges is that the underlying causes are predominantly behavioral, not purely technical. Communication failures, lack of leadership in a crisis, poor decision-making under pressure.
Rather than just a slip of the knife.
Often, yes. Imagine a complex tibial fracture fixation. A technical error might be misplacing a screw, a non-technical one. The surgeon not communicating the plan clearly, the wrong implant opened due to unclear instructions, the anesthetist not speaking up about a subtle change due to hierarchy. The consequences can be far more profound.
So even the best technical surgeon can be undermined.
Critically undermined by these non-technical failings. James Reason's Swiss cheese model is brilliant here.
Ah, yes, the holes lining up.
Precisely. Human error is somewhat inevitable, right? But serious accidents happen when multiple small errors align, passing through protective layers like holes in Swiss cheese. Our systems have safeguards, timeouts, checklists, trained teams.
But they can fail.
If those safeguards are weak or circumvented by human factors, a rushed timeout, someone not speaking up, a fatigued surgeon making a poor call, then a critical incident can occur. Reason argues that human resilience and expertise, especially NTS, are powerful protective factors.
They stop the holes aligning.
Exactly. Excellent situation awareness might catch a misplaced instrument pre-incision. Robust communication might address a positioning concern before nerve injury. NTS are often the last line of defense.
And Catchpole's work reinforced this.
Yes, Ken Catchpole's observations underscored it. His work found errors in surgical technique were often strongly associated with poor situation awareness. If a surgeon isn't fully aware of the patient's status, procedure progress, equipment, a technical error becomes far more likely.
And it wasn't just the surgeon.
No, other errors related directly to leadership and management skills, particularly among nursing staff.
Yeah.
It applies to the entire multidisciplinary team. The scrub nurse leading during equipment failure, the circulating nurse managing an unfolding problem, just as vital.
So NTS impacts technical performance too.
Professor Charles Vincent's work suggests so, yes, though the precise extent is still being investigated. A lapse in NTS, say poor team coordination, might not cause immediate harm, but could lead to increased stress, which then leads to a technical misstep, a cascade effect.
And Atul Gawande's analysis, that sounded quite stark.
Very stark. His analysis of surgical critical incident reports. Communication breakdowns contributed to a staggering 43% of incidents. Surgical team fatigue and stress, 33%.
Wow, 43%.
These aren't minor issues. They're pervasive, fundamental problems compromising safety. The human element is often where our systems are most vulnerable.
Wow, those are profound implications, Professor. It truly shifts the focus from just blaming an individual for a technical mistake to understanding of the systemic behavioral factors, team dynamics, communication.
Exactly. It's not about finding fault, but fundamentally improving the entire system to protect our patients.
A crucial move towards a more holistic, preventative, safer approach.
Right.
Recognizing the human factors involved.
Precisely.
It's fascinating how many concepts in modern healthcare, especially safety, have roots outside medicine. We just talked about NTS, but where did the idea of systematically addressing these skills, concepts like crew resource management, first emerge? It feels quite revolutionary in medicine, but it wasn't born here, was it?
You've hit on a crucial point. This entire movement, its origins are firmly rooted not in medicine, but in the aviation industry.
Aviation, really?
Yes, back in the late 1970s, driven primarily by NASA. And it wasn't some philosophical shift towards soft skills. It was a direct, urgent response to a grave problem: air crashes.
So it was driven by accidents.
By analyzing accidents, yes. NASA and aviation experts meticulously realized that a significant number of catastrophic failures weren't primarily due to technical malfunctions. The engines were fine, the wings intact, nor was it solely pilots making purely technical flying errors.
So what was it?
Time and again, failures in non-technical skills, poor cockpit communication, lack of effective leadership, inability to manage stress, a captain ignoring critical info from the co-pilot. These were frequently implicated as root causes. These human factors were literally crashing planes.
Gosh, so how did they tackle that?
Psychologist John Lauber was instrumental. He studied cockpit communication patterns extensively. His research led to a truly groundbreaking cultural shift.
Which was?
While maintaining hierarchy, the captain's ultimate authority, co-pilots and other crew were actively, explicitly encouraged to speak up, to challenge captains, highlight potential errors, voice concerns without fear of reprisal.
That sounds radical for that time.
It was a radical departure from the traditional, often authoritarian cockpit culture. It empowered all crew members to contribute critically to safety, cultivating a culture where critical feedback, even dissent, wasn't just tolerated, but expected,
Yeah.
valued. A huge psychological hurdle, but the impact was undeniable.
And the training evolved, too.
Oh, remarkably. It started with relatively simple workshops, didactic sessions on communication, teamwork. But as understanding grew, it rapidly progressed to sophisticated, high-fidelity, full-mission simulations.
Like the CRM you mentioned.
Exactly. These weren't just theoretical exercises. They were immersive, realistic scenarios. Engine failures, instrument malfunctions, severe weather pushing crews to their limits. The explicit aim: improve critical incident reporting, foster a robust safety culture, prevent accidents by training crews to work together, communicate under pressure, make critical decisions as a cohesive unit.
So CRM came directly from aviation's needs.
Yes. This paradigm, initially crew resource management, evolved into crisis resource management, CRM, reflecting its broader applicability. And it wasn't just medicine that noticed. Nuclear power, other high-stakes industries swiftly adopted these principles.
It's powerful, isn't it, that what started in a flight deck can save lives in an operating theater.
A powerful testament to the universal applicability of these human factors.
That's a truly powerful historical lesson. It really demonstrates how vital these skills are across diverse, high-risk fields. With such compelling evidence from aviation, how then did our profession, medicine, begin to integrate these NTS principles? And what measurable impact has it had, particularly in surgery? I imagine there might have been some initial resistance.
You're absolutely right. There's always a degree of innate conservatism in medicine, perhaps especially surgery. But the profession, to its credit, eventually recognized the immense value, especially after reports like, "To err is human."
So who led the charge?
Anesthetists were notably at the forefront. Given their high-stakes environment, managing complex physiology, working in close-knit teams, needing rapid decisions, the parallels with aviation were strong. They saw themselves as the pilots of the patient's physiological journey.
And specific pioneers.
David Gaba, an anesthetist at Stanford, was a true visionary. He developed an anesthesia CRM course that became a global benchmark.
What made it so effective?
It wasn't just lectures. It was a brilliantly designed, mixed-method approach, blending theory with powerful visual aids, videos of actual anesthetic mishaps, vivid, often disturbing examples of NTS failures.
Wow. Confronting.
Very. Followed by intensive, immersive simulation sessions, managing realistic patient scenarios, and crucially, immediately followed by thorough, structured debriefing.
The debriefing was key.
Absolutely key. A safe, non-punitive environment to reflect, understand errors, learn without fear of judgment. That combination, didactic, simulation, debrief, proved incredibly effective, moving NTS training far beyond haphazard, informal learning.
And this spread.
Gaba's team even distilled CRM into a concise 15-point outline, a kind of CRM playbook. It's been adopted extensively, forming the keystone of modern training across many medical and allied health curricula, emergency medicine, trauma teams, scrub nurses, general nursing. A foundational text, almost.
And the impact on outcomes. You mentioned measurable results.
Significant and objectively measurable. Consider the landmark Naley study in the New England Journal of Medicine. Compared one-year mortality across 108 VHA hospitals.
What did they find?
Simply striking results. Hospitals with comprehensive medical team training program, essentially, NTS CRM training showed an 18% reduction in annual mortality compared to just 7% in the control group.
18% reduction. That's huge.
A measurable, life-saving difference directly attributable to these interventions. Even more compelling, a dose-response relationship. For every additional quarterly training session, a further reduction of 0.5 deaths per 1,000 procedures. Hard data proving life-saving improvements systemically.
Professor, an 18% reduction across a system like the VHA is phenomenal. It powerfully underscores the measurable life-saving benefits, the real-world impact of addressing human factors.
Precisely. And in the surgical context, the Royal College of Surgeons of Edinburgh, RCSED, has truly pioneered NTS training and research for surgeons.
What did they develop?
They're non-technical skills for surgeons, or not DSS, masterclass, an intensive one-day simulation course facilitated by a multidisciplinary team, surgeons, anesthetists, psychologists. They also created Knots in a Box, an e-learning resource, making training more accessible.
And assessment, how do you assess these skills?
A key development was Stephen Yule's creation of the NotDes assessment tool, groundbreaking, a behavioral rating system allowing for the first time objective assessment of NTS in surgeons.
Moving beyond subjective impressions.
Exactly. Before, assessing soft skills was often subjective, anecdotal. NotTS provided a structured, validated way to evaluate specific NTS behaviors, allowing specific, actionable feedback, proven reliable and valid, transformative for evaluation.
And others built on this.
Ken Catchpole's Oxford group expanded brilliantly, developing tools for the entire surgical team. Oxford No-Tech INT for teamwork assessment, and their observational teamwork assessment tool, OTS.
What does OTS measure?
Procedural tasks related to patient, equipment, communication, plus team behaviors like cooperation, leadership, mutual support. Impressively, OTS has been validated and translated worldwide, accounting for local cultures, shows its robust applicability.
That's a huge amount of progress, especially with validated assessment tools for these complex, subtle skills. But I imagine assessing them isn't without challenges. What criticisms have arisen regarding NTS assessment? It seems inherently harder than assessing technical skill.
You've hit on a critical point. Immense progress, yes, but not perfectly smooth. The literature highlights valid criticisms. One major issue: they're often observer-dependent.
Meaning bias can creep in?
Potentially, yes. Reliability and consistency can vary depending on the observer, their training, their biases. It introduces a subjective element many find problematic in evidence-based medicine.
And applicability across specialties.
Another point: most validation studies were predominantly in general surgery. There's specific applicability and efficacy across all surgical subspecialties: orthopedics, neurosurgery, cardiothoracics. Each with unique dynamics still needs more rigorous investigation. We can't just assume one size fits all.
Okay. What about the evidence for training effectiveness overall?
Systematic reviews yield somewhat mixed results. Moderate evidence for teamwork improvements, yes, but lower evidence for patient-centered communication and decision-making, and very low for direct patient safety outcomes.
So proving the direct link is hard.
Often, these studies rely more on qualitative methods for validation and reliability, valuable for understanding perceptions, processes, but sometimes lack the hard quantitative data demanded for definitive proof of efficacy, like for a new drug. Rigorously demonstrating the direct, measurable impact on safety from every facet of NTS training, with that level of statistical power. It remains an area for continued research and refinement. We know it works intuitively and from proxy measures, but proving direct causation at population level is complex.
Okay, that gives us a really nuanced picture across general medicine and surgery. But now let's bring it specifically home to our field. The orthopedic surgeon, often painted with a certain stereotype, maybe more so than others, the jokes, big hammers, small brains.
Ah, the venerable orthopedic stereotype.
Given that, how has this specific community approached NTS integration? What are the unique challenges and advancements within trauma and orthopedics pushing this agenda?
You're right, the perception, often caricatured as a man of enormous build and great strength, and perhaps a little slow.
Affectionate, maybe, but telling.
Exactly. It prioritizes physical attributes, strength, endurance over cognitive agility, or interpersonal finesse. I've heard my share of those jabs. Interestingly, some tried to dispel the myths. Subramanian in the 2011 Christmas BMJ.
What did they find?
Orthopods actually had significantly higher IQ scores and grip strength than anesthetic colleagues. So, slow is busted, strength holds true. But the stereotype highlights the historical underemphasis on NTS in our specialty. The assumption was technical brute force and knowledge would suffice.
But the reality is different.
Absolutely. Trauma and orthopedic surgeons face unique challenges demanding exceptionally strong NTS. Our procedures involve complex interactions with a broader range of team members than some other specialties.
Radiographers? Industry reps.
Exactly. Close work with X-ray radiographers for imaging, dedicated scrub teams, circulating nurses, often industry reps for specific implants or equipment. This multi-stakeholder, often bustling environment makes effective communication, distributed leadership, sophisticated situational awareness absolutely critical.
Can you give an example?
Imagine a complex acetabular fracture fixation. Miscommunication with the radiographer on image angle, lack of clarity with an industry rep on screw size, immediate significant consequences for safety and efficiency. Wrong implant opened, waiting for the C-arm view. It accumulates risk. Plus, Heavy, complex machinery, power tools, traction tables adds another layer needing precise coordination.
So how did orthopedics start addressing this specifically?
A novel, bespoke one-day NTS course was meticulously developed in 2013. Department of Trauma and Orthopedics at the Royal London, collaborating with the Education Academy at Barts Health.
Bespoke, tailored just for orthopods.
Exactly, not generic. Designed from the ground up for orthopedic surgeons, recognizing our unique blend of mechanics, trauma, teamwork needed its own focus.
How'd it run?
Started with a didactic overview theory, relevance. Crucially, participants completed consent forms, ensuring confidentiality,
Right.
fostering an unthreatening learning environment. Psychological safety was paramount for open participation, honest reflection.
No fear of judgment.
That was the aim. Pre-course questionnaires gauged existing NTS experience
Mm-hmm.
and was intentionally multidisciplinary junior trainees, registrars, and allied health professionals like scrub nurses.
Interprofessional learning.
A key, powerful feature. Understanding each other's perspectives, roles, NTS needs in a shared space.
And the scenarios, were they orthopedic specific?
Absolutely, the real strength and innovation. Orthopedic critical incident reports from the Royal London underwent meticulous thematic analysis to identify recurrent, real-world NTS failures.
So based on actual local issues?
Yes.
Yeah.
These insights were used to develop 6 highly realistic scenarios mapped directly to the curriculum, designed to explore those 15 CRM key points. And brilliantly diverse.
Like what?
2 clinic-based, angry patient, tricky baby hip ultrasound. 2 ward-based, inappropriate consultant behavior, hemorrhage versus PE post-op. 2 theater-based, arthroplasty, cement reaction, critical equipment failure.
And faculty running it.
Also strategically multidisciplinary. Senior orthopedic consultants, experienced anesthetists, ODPs, scrub nurses, each brought unique perspectives, enriching facilitation and debriefing. Scenarios observed via two-way mirror, recorded with HD audio-visual.
For playback during debrief.
Exactly. Objective playback during structured debriefing, led by trained faculty, pinpointing CRM points, facilitating deep reflective learning. Powerful for self-discovery.
That sounds incredibly well thought out, Professor, specifically for the orthopedic environment. So what was the tangible impact? What evidence did you find regarding effectiveness, and how did it influence practice?
The impact was quite positive, showing measurable gains. Heaton and colleagues examined feedback from 26 orthopedic registrars on the Royal London course.
What did they find?
Participants' understanding of NTS and their role in safety improved significantly. Likert scale rating went from 3.0 to 4.2 on average, a clear enhancement. Critically, they reported the unthreatening learning environment, vital for engagement. And high face validity for the scenarios felt realistic, relevant.
An objective assessment.
Miguel and colleagues used the RCS NoteAssess tool to assess trainees in the scenarios. Insightful findings. The scenarios effectively differentiated between experience levels, a good sign of validity. Plus, high inter-rater reliability among multidisciplinary assessors, consultants, anesthetist nurses, all trained on NoteAssess, showed consistency, fairness.
And the feedback was good.
Overwhelmingly positive. Highlighted the tailored approach's value. 100% rated the multidisciplinary approach very beneficial. 85% found scenarios very realistic. 92% rated debriefing very useful.
And the impact on teamwork.
Perhaps most importantly, the allied health professionals involved reported significantly enhanced teamwork with orthopedic surgeons post-course. A fantastic outcome, showing the positive ripple effect, improving communication, fostering cohesion.
So this bespoke approach is catching on.
Rightly gaining significant traction. Other centers, like Torbay Simulation Center, developed similar programs, presented findings at the BOA Congress in 2017. Torbay's findings confirmed an unmet training need, overall NTS performance often below acceptable standard, particularly analytical thinking in emergencies. Reinforces the systemic problem.
So what's the best way to teach NTS then?
Cumulative evidence consistently shows it's most effective, not through passive lectures alone, but a powerful amalgam. The apprenticeship model learning by doing under supervision combined with rigorous high-fidelity simulation. Active, experiential learning, immediate feedback, safe practice, embedding skills into professional muscle memory.
And simulation can go beyond the dedicated suite.
Absolutely. In situ simulation, taking scenarios into live clinical settings, like a trauma bay. Steinman showed this improved teamwork and performance in both simulated and actual trauma settings. Powerful transferability. Even high-fidelity mannequins, like Simmon 3G, are portable enough for field use, like military trauma training, preparing surgeons for extreme situations.
It's clear then the appetite for and impact of this tailored training is significant. But it's one thing to design courses top-down. What do orthopedic surgeons themselves, particularly those in training, actually feel about learning NTS? What are their real-world perceptions? Their buy-in is crucial, isn't it?
Truly vital. Their perceptions influence engagement, efficacy, the future direction of education. Vigela conducted a rigorous qualitative study, MSc Thesis 2017, investigating exactly this: trainee perceptions of NTS training and how these tacit skills are acquired.
How did they approach it?
Recruited 2 cohorts of trainees from Northeast Thames. One had done the Royal London Immersive Simulation course, the other had conventional training only. Allowed for rich comparison, used semi-structured interviews for in-depth exploration.
And analyze the themes.
Yes, audio recordings transcribed verbatim, then Braun and Clark's inductive thematic analysis using interview software. Identified overarching themes from 10 interviews trainees from first year to senior fellows.
What were the main themes?
7 emerged. First, good overall understanding. Trainees largely understood NTS concepts, unequivocally recognized their importance for patient outcomes and error prevention. Not an alien concept, they intrinsically grasp its value. Second, and crucial, underrepresentation. Unanimous, resounding agreement that NTS are poorly acknowledged, undervalued, largely absent in formal training. Predominant emphasis still squarely on technical proficiency, the hardware. A clear, concerning disconnect.
So how do they learn NTS now?
Theme 3, major learning methods. 2 pathways stood out. Immersive simulated scenarios consistently found excellent, effective. High face validity, huge benefits from peer and allied health professional learning via debriefing. Diverse perspectives they wouldn't get otherwise.
And the other pathway?
On-the-job learning. Described as more nebulous, less structured, organic, observing, reflecting on experiences, absorbing skills informally from the environment, influenced by workplace culture, informal consultant feedback. Effective, certainly, but less explicit, less consistent.
What motivates them to learn NTS?
Theme 4, motivation to learn. Primarily driven by a deep desire to improve patient safety, commendable, but also significantly motivated by practical career progression. NTS gaining focus in exams, interviews, provides a strong impetus.
And work-based assessments, do they capture NTS?
Theme 5, role of work-based assessments, WBAs. Trainees found their role in assessing NTS unclear, inconsistent. They strongly suggested a need for increased, explicit emphasis on NTS within WBAs and the broader curriculum. They want these skills formally recognized, assessed, integrated.
Interesting. Did they feel NTS learning starts late?
Theme 6, quite interestingly, early learning. Trainees reported learning about NTS from very early stages, medical school, insights from other industries like aviation, even profoundly from outside professional life experiences, sport, team roles. Suggests powerful, often subconscious acquisition, even before formal training names it.
Any other themes?
The 7th theme really synthesized much of this, highlighting the perceived value versus the actual structured input they receive. A clear call for change.
That's incredibly insightful. These findings clearly demonstrate trainees recognize NTS importance alongside a very clear call for more structured, explicit, integrated approaches. It sounds like they're not just ready for this shift, they're actively advocating for it. The future orthopod will certainly be more than just eyes of a hawk and hands of a lady. So, as we wrap up this deep dive, it's abundantly clear the era of the lone, technically brilliant surgeon is indeed evolving, moving towards a far more sophisticated model. Collaborative, cognitively agile, communication proficient practitioners are paramount. Non-technical skills, as we have explored, aren't supplementary. They're foundational to modern orthopedic safety, efficiency, excellent outcomes.
My closing thought for you, our dedicated listener, is this. The evidence is overwhelming. Excellence in orthopedics now extends far beyond the scalpel, the drill, the perfect reduction. The real challenge, perhaps the most rewarding, lies in continuously honing these human factors, our collective ability to think critically, lead effectively, communicate impeccably under pressure. So the question is, how will you champion this holistic approach within your own practice and teams? What concrete steps will you take to integrate and advocate for these vital skills, shaping a safer future for orthopedic care?
A powerful call to action indeed. Professor Mo Imam, thank you for guiding us through this incredibly enlightening deep dive into non-technical skills in orthopedic surgery. Your insights have been invaluable.
My pleasure entirely. A vital conversation to have.
If you found this discussion valuable, please do take a moment to rate and share Deep Dive Ortho with your colleagues. Until next time, stay curious and keep learning.